Well, good morning. It's always an absolute pleasure to stand up here and kick off the course, the 9th annual LI Live Endoscopy course. I'm going to petition that we change the title to the next year, the 10th annual Live Endoscopic Surgery course, because that's what we're really talking about here. And I'm also very proud and honored to be the Pete Stevens Memorial Lecturer. So I do have some COIs that you need to see there. It's basically 2. And what are my objectives this morning for my presentation? The title is Third Space Endoscopy. And if you look up the definition for third space, it's a very interesting concept. It's a socio-cultural concept that deals with the reality, the unreality, and then trying to tie it in together. And so I suppose you could look at this course with the contents of the course as somewhat unreality, but we're tying it together and bringing it to reality. But I will define third space in the context of what we're going to be doing through this entire day and tomorrow morning as well. I'm going to highlight the current practice in the third space, and then I'm going to make some editorial type comments. Why do we need it? Who can do this? And how do you get there? So first of all, what is third space endoscopy? I alluded to this in my opening remark, and it's basically endoscopic surgery. So third space endoscopy is the new notes, and it is that alphabet soup: POEM, POP, EFTR, STER. I also included abscess drainage and fistula repair because these two areas are currently evolving. We know that abscess drainage is a very vigorous endeavor to expedite the resolution of abscesses. One has to be fairly aggressive in these, and there are new ways now of opening the gut wall by suturing the enterotomy sites, bypassing completely the stents that everybody has become quite familiar with. So there are new approaches, and these new approaches really do fit in the world of third space. And fistula repair, we're learning we have to be much more aggressive with fistulas, including completely excising the opening of the fistula as it enters into the tract. And so long-standing mature fistulas that are well epithelialized are really not going to close unless, or are not going to close quickly unless you really cut them out and then close the gap that you've created. So very, very different, very, very interventional surgical endoscopy. Third space endoscopy requires a unique understanding of not only the luminal anatomy, but you have to be cognizant of the intramural anatomy now, and you have to be very cognizant of the extraluminal anatomy, especially to avoid serious adverse events. It's basically an enrichment of care. So once again, we're talking about endoluminal surgery now. We're talking about working in an interventional suite, not an endoscopy room. We've got to throw away all that language. It's a new world order. It's an interventional suite that's especially equipped with personnel and equipment to enable the new notes. And we've already heard about anesthesia. Anesthesia has now become a key element to the success of surgical endoscopy. It doesn't succeed unless you have an anesthesia team that understands this is not typical endoscopy. These are procedures that will last an indeterminate period of time, especially with new procedures, and requires truly a team effort as well as specialized tools. So what I'm going to do now is go through the individual third space procedures. I'm not going to provide you with a lot of data. I'm going to try to summarize these procedures. You're going to see them shortly. And so we'll put it all together, and I'm going to give you the highlights of each procedure and what you should take away with you. So what about POEM? So now we know that POEM is an established management option for achalasia. It's been proven to be efficient, safe, and we have now long-term efficacy data. What else? What's new with POEM? We know now that it can be applied successfully with patients with having diffuse spasm and other hypercontractile disorders. It must include dealing with the lower esophageal sphincter as well, not just the body of the esophagus. We know now there are solid studies to demonstrate that POEM can cause gastroesophageal reflux. But the good news is that most of these patients really are asymptomatic. And the number of true PPI refractory cases are pretty rare. But what else do we know about this GERD association? There's only one reported stricture, but in the world of endoscopic surgery, it's a grand opportunity for endoluminal therapy to expand, and that's what I'm going to tell you about. So just looking at the GERD cases, this is a before and after, simply suturing the gastric cardia, doing a cardioplasty to help the rare patient who has a PPI refractory GERD. So it opens up a new dimension. It opens up a new, easy approach to take a look at treating gastroesophageal reflux disease. What else does it do? It's reopened the door to mediastinal intervention. Because we're comfortable doing POEM procedures with either circular myotomy or full thickness myotomy, which is a more common occurrence, we know that the safety profile, especially the infectious profile, has opened up this opportunity to take a look at mediastinal intervention. And when I developed tunneling years ago, it was specifically with the intent of trying to explore flexible endoscopic mediastinal intervention. So we're going to walk you through that pretty quickly here. So we have what we have is a diagram of the mediastinum, and we're very good at getting into the posterior mediastinum. We, with some difficulty, depending upon exit location, can access other areas of the mediastinum. Superior mediastinum is pretty rough. This is what you get into, and this is the world that it opens up for you. So it opens up a world of lymphatic approach for lymph nodes, lymph drainage, opens up a vascular world, and obviously in that gap it sits behind the heart, and it gives you access to the heart, the pericardium, and all those interesting structures. This is a video that's going to play. It's going to show you a entry into the mediastinum, and it's once you see that entry, you'll notice that things rapidly can change. One has to know for sure the extraluminal anatomy of the gut. We're going to have to, I wonder if I was hoping the bar on the bottom of that would pop up and we can kind of speed this along. Very good. Yep, take it there. So here we go. So we just used a balloon, basically, not an ESD approach, a rapid balloon entry into the distal esophagus, and we're sitting above the pinch of the lower esophageal sphincter. It's a perfect area to enter the mediastinum because it's a fairly uncrowded space. And what you're going to eventually see here is a cap-style myotomy. And that's what first raised the spark in our minds that, oh, this could be probably a method to treat achalasia. Not quite this way, but the way you're going to be seeing it today. But at any rate, it created a nice big hole that you could advance an endoscope into the mediastinum. This hole's a little snug, so we're going to do kind of a hybrid myotomy for entry into the mediastinum using the needle knife you had seen at the beginning of the procedure. But we're just going to cut this open a little bit. You can see already a little bit of space back there, so we're looking down towards the diaphragm. And that allows you to eventually pop the scope out of the esophageal wall and into the posterior mediastinum. It's an area that your anesthesia team has to be especially prepared for because there's all kinds of issues that can arise by pumping CO2 into the mediastinum. It normally doesn't like it. It's kind of crowded in the beginning, and one has to get an orientation of where's lung, where's diaphragm, where's the aorta, where's the esophagus that you've exited through. And this is the candy cane approach to the mediastinum, where the scope exits the distal esophagus, retroflexes, and you're looking up towards the apex of the middle mediastinum, and coming out and looking at diaphragm again. So there are, it's a whole new world of endoscopic access. The type of myotomy that you saw, that was an EMR type myotomy, gives you a pretty large defect in the esophageal wall. But with the SEMF attitude, meaning submucosal endoscopy with mucosal flap, this is the mucosal flap covering that big myotomy hole, seals it very, very nicely, and it also eliminates those issues about sepsis. So, thinking about where POEM is leading us, what's hot and what are the low-hanging fruit to mediastinal intervention, and cardiologists like this. In fact, we're currently doing animal work, exiting the esophagus and watching the cardiologists do their ablation. One of the most serious adverse events of ablation techniques is they can ablate full thickness through the heart, full thickness through the pulmonary artery, and you can have massive exsanguinating hemorrhage. But if you have a scope there watching the EP ablation, you can tell the cardiologist, oh, we're starting to see a little whitening on the adventitia of the vessel or on the pericardium. You better stop. And so it's something where you don't have to do a lot, but you can save lives. Lymph node sampling and lymphadenectomy, this might be an area that perhaps EUS does a pretty sound job, but maybe this could be a better job with this approach. Some people have spontaneously said, oh, you know, that Lynx device for gastroesophageal reflux, can you do that? Can you put that in place with an endoscope? Well, I will tell you we did a lot of work doing that, and it's pretty impossible to do in an efficient way. So it's a great idea, but it's got some challenges. This is the real reason why we in our developmental endoscopy unit started looking at using myotomy, esophageal myotomy, to enter the mediastinum, is to take out the left atrial appendage. There's cardiologists will tell you they think there's an epidemic of atrial fibrillation in the country right now, and all sorts of people walking around with antithrombotic therapy. But once you exit posteriorly, you really have good access to the left atrial appendage, provided you know the anatomy, and you certainly can put an endoloop around it and cut it off. And that would eliminate a patient's need for lifetime antithrombotic therapy. It's already been done in an animal model, but this is a whole new world order of endoscopic surgery. POP. Here we go. Here we're in the alphabet soup. Does everybody know what POP is? Per-oral pyloric myotomy. So what do we know about POP now? Well, there are now clinical experiences reported, multi-case clinical experiences, and the January issue of Gastrointestinal Endoscopy actually highlighted these, both with two multi-case reports and two expert editorials. And importantly, now the experts are on the side of per-oral myotomy at the level of the pylorus. We know now there's been key procedural anatomy that's been identified, useful for training and proceeding forward. We know that the motility experts are identifying patient subgroups who are ideal candidates for this procedure. And it's also stimulated new terminology. So what should we call this? Should we call it POP? Or should we take POEM as the basis procedure? Because that's what these things are. They are myotomies. And do we have just plain POEM or E-POEM, meaning in the esophagus, G-POEM for the pylorus, Z-POEM for Zenker's, or AR-POEM for anorectal endoscopic myotomy, or PREM, per-rectal endoscopic. So we do have an alphabet soup, but it would be useful to standardize terminology. And you've already seen and heard this morning that we're talking POP, now we're talking G-POEM in this course. So we're moving ahead in surgical endoscopy. We're going to shift now to full-thickness resection. The concept, organ-sparing, en-bloc, full-thickness, endoluminal, flexible endoscopic excision of focal pathology. That's our definition. It's useful for diagnosis. At Mayo now, we're starting to do this to try to discriminate motility disorders by capturing the muscle layer and performing immunologic studies and immunofluorescence studies. And they're actually trying to segregate, for example, the gastric motility disorders to look for patients who would benefit from G-POEM. It can be a primary treatment, and it also can be disease containment in patients who can't undergo more standardized surgical operation. We know that we can minimize patient morbidity and mortality, and it's performed outside the traditional operating room, which has for it economic benefit and healthcare expenditures. So full thickness resection not only benefits the patient, it benefits healthcare costs as well. The indications currently, and as we'll see today, subepithelial tumors. There is work outside the United States in early gastric cancer. We don't see a lot of that here. And it definitely is an area for difficult colon polyps. These are the types of lesions that have sparked interest in full-thickness resection. You'll see those today. So what is the published experience? It's focused on stromal tumors. The series have highlighted that lesions are ideally suited that are 2 to 3.5 centimeters in diameter, and there's been a variety of closure methods in these cases that have been reported in the literature. Now we have available to us endoscopic suturing that can facilitate closure regardless of the size of the lesion that these experiences have been limited to. But if you look at outcome analysis in these reports that are listed below here, it very specifically compares favorably to laparoscopic resection, including cost analysis, which is huge. And if we compare it to ESD, it's kind of the gold standard to try to remove some of these lesions, it proves to be easier and even faster. So what about colorectal neoplasia? This is the concern in the United States. This is the main interest level. We had a breakthrough live case by Sergei Kantsevai, who will be joining us later in 2011 in Barcelona. His case success was dependent upon the new world of endoluminal suturing. There have been a variety of over-the-scope clip experiences. Again, not surprising. It's an easier technique to apply a clip. It's more familiar in use. But the bottom line is it demonstrates significant success. The downside is it's got a fair limitation insofar as the size of lesions that can be approached. That can be changed when one becomes facile in the new world order of endoluminal suturing. But this is basically what people have been reporting to date using that style of device. So what are we learning about full-thickness resection? We've learned, and you'll see today, that we have to use an ESD technique to excise the targeted areas. That minimizes and it delays the actual full thickness component and the potential risks and hazards of opening up the environment outside the gut lumen. It allows us to anticipate and recognize large vessels, which is probably the greatest threat to full thickness resection, especially in the colon. And we're also learning in the colon, as well as elsewhere, that maybe serosa to serosa undermining pseudopolyps might be desirable if it can be done conveniently and efficiently to isolate target tissues and also reduce issues. So the concept is to take a target lesion, create a pseudopolyp, undermining it in some fashion so that it can be cut off conveniently without causing any contamination of cellular contamination or luminal contents outside the organ. And there are some devices that people are looking at, again, to try to facilitate that. Now we're going to jump to STER, submucosal tunneling endoscopic resection. So fortunately in our evolution, we developed the submucosal layer, a fantastic layer, nice and loosely applied to the more vigorous layers such as the muscle layer and an overlying mucosa, and a great world, a third space to enter and do endoscopic resection. This is a very recent publication. If you want to get a little more familiar with STER, it really summarizes this area very, very nicely. And what do we know now? We know that the ideal locations for STER are in the esophagus, gastric cardia, greater curve, body area, and the rectum. The indications are resection of subepithelial tumors, especially arising from the muscularis propria, and it seems that the max target size by literature is about 3.5 centimeters that you could get out somewhat conveniently from these tunnels. The en-bloc resection rate is fantastic, and the new hot area for STER is resection of epiphrenic diverticula. What we know is commonplace is the development of pneumomediastinum, pneumoperitoneum, and subcutaneous emphysema. These are not adverse events anymore. These are just side effects to the procedure. They're all done with CO2, and patients resolve those, or you can resolve those patients pretty quickly with needle decompression. The serious adverse events that we have to keep in mind are those patients that occasionally develop a pneumothorax and we'll need drainage for that, and those patients who develop a significant hematoma as a result of an extramural bleeding event. So why do we need third space intervention? We need it because it does a better job at patient safety. We need it because it does a better job at healthcare delivery and in economics for difficult problems that can otherwise be very expensive to manage with standard surgical approaches. And it's part of the evolution of endoscopic endoluminal surgery, which is what we're all going to walk out of here today and call this type of activity. Who can do this? It requires an advanced endoscopy practice. And what am I talking about? I'm talking about schedule flexibility. It can't be a rigid, structured endoscopic schedule. It's got to be a practice that really, truly can allow significant time flexibility, hours per case. It requires a practice that needs anesthesia to fully support that concept, that this is endoscopic surgery. There's an element of unpredictability that includes time, and appropriate patient care can be delivered when that frame of mind is fully developed in concert with the proceduralist. It's going to require an advanced practice that has all the equipment and supply available. That we mentioned suturing devices. We talked about new over-the-scope clips that provide full thickness resection. It also includes availability of EUS. Even though we don't see EUS in this course, sometimes you have to interrogate a lesion before you tackle it, just to make sure you fully understand vascular supply, where it goes outside the gut lumen, and in order to make your plans. What do you need is a pre-existing procedure mix experience. You certainly need experience in colon and foregut EMR, ideally ESD. You need an experience in ERCP, especially needle knife sphincterotomy, EUS FNA, and you also need to have experience in endoluminal suturing. These are the basics that you need to launch yourself into a practice of endoscopic surgery. But how do you get there? That's the challenge everybody has to face. And you get there by taking all the advanced skills courses with hands-on components that you can expose yourself to. You may have to travel abroad for training and early clinical experience. You have to identify a mentor who can specially train you individually, one-on-one. Stavros described a course this June that gives you that kind of an opportunity. And then you have to arrange for proctorship. Somebody's going to stand by your side in your blocked schedule and coach you through or support you through tackling these cases. And ideally, because of relative infrequency of cases, you need an animal lab to access so that you can maintain your skills and keep practicing these skills over and over again, which is what surgeons do. So there you go. That is the third space and all the elements that comprise the third space. As I said, it's a new world order, and we're going to witness that today. Thank you.